So some of you I know, Kyle and Jana, hi.
Hello.
Others, nice to meet you virtually. And I'm Stephanie Greenham. I'm a psychologist at CHEO here in Ottawa. I've been involved in inpatient mental health and outcomes management for about 18 years. And the reason Lisa has asked me to present to you is that I've been involved with inpatient benchmarking both at the provincial level here in Ontario as well as the national level for a number of years. And through the activities of those two groups, we've compiled some data, a bit of a snapshot of inpatient mental health care. And I'm going to speak to you about that today. First, about the role of, can you advance the slide, Lisa?
Oh, sorry, yes.
Yeah, I realize I can't do that anymore. Thanks. So first, in terms of, what are these networks? I'm involved in two inpatient networks for child and adolescent inpatient psychiatry. One is the Ontario network on CAPES, and the second one is a national, looser network, but a network nonetheless across Canada. And so I'll speak to you just a little bit for those of you who aren't familiar with what on CAPES and CAPINet are all about, and the role of those two networks in the benchmarking that we've accomplished to date. And then I'll provide you with a summary of some of the most recent national data that we've compiled, and then hopefully that will stimulate some conversation and some questions at the end. And I'll try to stick to the timeline, although I know if we're starting late, Lisa.
That's all right.
Okay, you can go ahead and advance. Thanks. This is really meant to characterize, at least in Ontario and probably across the country as well, what inpatient care looked like. We were all in silos, meaning that we didn't know anything about each other. We didn't know where inpatient beds were, either in Ontario or really across Canada. We might have known within our own local areas, but we were very isolated from each other. And this, was as recent as, 2006. And so in 2006, the Ontario network really formed. And now, 2016, but also now in 2018, we've really worked hard to build a community of practice amongst ourselves. Starting kind of fulsomely in Ontario, and what we've tried to do at the national level is kind of spread that model across the different provinces and try to pull a larger community of practice of inpatient care together. And, you folks are a community of practice as well, and so you know what that entails and really kind of where it starts. On CAPES really was a grassroots effort. We at CHEO, we were able to secure some funding to have a meeting, and we did a little bit of work to identify where inpatient units were in Ontario. We actually had to, we asked our Ministry of Health if they could provide us with a listing, and they had no such list. So we had to do that work ourselves. And now we have a list, we have a directory, we have a website, we have a community of practice. So it was really about pulling ourselves together and coming up with some common purpose, what this network wanted to do, what were the objectives and the goals of coming together. Why did we want to do that? So if we could look at the next slide, you'll see that in that 2006 initial meeting, everybody showed up, and we had every single known unit at the time in the room, and we got some consensus around what could be goals for a network. And these were the things that we heard consistently across sites. We wanted a way to exchange knowledge about about the services, about the patients, about the practices, to get a better knowledge of a shared knowledge as well of what's happening in inpatient care. Establishing benchmarks was one of the initial clear goals, and that's why I've highlighted it there. As well as going on to develop some best practice guidelines that we could, again, sort of learn from each other, build on the evidence, and try to provide a little bit more of standardization of care for children and adolescents who end up in inpatient psychiatry units. So you can see very early on with the OnCAPES group anyway, that the benchmarking was a core objective. People wanted that knowledge and they wanted to contribute and build that knowledge. At the national level, we, even before we got OnCAPES started, we had started to, a year earlier even, put some, sort of feelers out there to get a sense of what interest would be there for the Canadian, at a Canadian level, at a network level. And so using the Canadian Academy of Child and Adolescent Psychiatry annual meetings as a mechanism for face-to-face communication and networking, we have pulled groups together, not every year, but since 2005, and there has been consistent interest and endorsement of the idea of a national network. So, if you go ahead and advance the slide, Lisa, these are some of the reasons why we feel, we've heard from people, why do we want to network and connect and build a community of practice? Just like in really a lack of access to information about what services are available across Canada for kids. We have no easy mechanism for us to learn about each other, to connect, to communicate, to share. Again, we heard consistently an appetite for meaningful benchmarking and outcomes data so that we could speak about our very specialized care with a collective voice. There's been a desire, again, to learn from each other, to not always reinvent the wheel, to share unique practices and successes and share policy ideas and brainstorm challenging situations, as well with the ultimate kind of goal to develop guidelines or standards or potentially collaborations to do more formal research. If you go ahead, Lisa. Right. So, of course, there are always challenges to sustainability, and at the national level, particularly, our progress has been, I would say, slow. And Jana, you've been in on that work from the early days too, and so you can attest to some of the challenges that we've had just in sort of keeping the momentum going. There's a lot of turnover and change in the inpatient world, and keeping people consistently engaged with the process and finding the resources to do the work has been one of the big challenges. If we go ahead, Lisa. And so, at both the provincial level in Ontario and at the national level with the CAPINet network, we have attempted to do, not every single year, but we have a series of annual benchmarking surveys that have been undertaken by the steering committees of each of those networks. Go ahead. And so what we've learned from our surveys over the years is that inpatient care for mental health for children and adolescents are largely provided on generic units. There are a couple of specialty inpatient units across the country, the concurrent unit at CAMH as an example of a specialty unit, and there is, we're aware of an autism inpatient unit in Quebec. But for the most part, our inpatient psychiatry units are generic, meaning they will take all sort of presentations and all disorders. But the other thing that is, very clear is that across units, there is wide variability in terms of what the model of care, what the practices are, what the kind of interventions and programming looks like. Despite that, we can say that the services predominantly are of brief acute crisis model or some blend of crisis and planned treatment. There are a few sort of units that will focus on elective, longer-term treatment, but the vast majority are acute crisis plus or minus assessment and some intervention. But there's, again, no consistency in terms of inclusion or exclusion criteria in terms of what age children can access inpatient care, in terms of you know, who would be considered to be not appropriate for one unit, may be very appropriate for another. So there's really a lack of, as I say, lack of standardization and wide variability. I just put up a couple of references in terms of the previous work that we've done where some of these points have been drawn from. And so, you know, what we've done is try to, this is the first time that we've really combined our Ontario survey, which is done, you know, sort of separately within Ontario, with the national survey. And so for the fiscal year of 2015-16, we were able to get about 80% of the units that we are aware of respond to our benchmarking survey. Now you can see from the distribution, half of those units are in Ontario, and the other half are spread across the provinces that you see. We had underrepresentation in Quebec and New Brunswick for this particular round of surveying, but the data that I'll summarize for you represents almost 11,000 discharges in that fiscal year, and so we were very pleased to get the participation that we did. Go ahead. So these are just sort of a snapshot of some unit descriptions. So, you know, your typical unit is about 9 to 10 beds. There's a wide range there, as you can see. As I mentioned earlier, predominantly a mix of crisis and elective admissions on the units, with about, you know, a quarter of units being only acute crisis and a very small percentage being only elective units. There is only, of the units that responded, only one child unit, which is in BC. The rest are a blend of child and adolescent or only adolescent patients that are admitted. As I mentioned before, we have very few specialized units, and the vast majority have the capacity to admit involuntary patients under Mental Health Act. About 3/4 of the admissions are emergent, and so speaking again, sort of matching up with the crisis nature of the services. Our rate of involuntary admission, though, across Canada is quite high, almost 50%, and that's much higher than that's been documented in, you know, other international surveys that have been done, as you can see. And so we don't quite understand some of the reasoning behind that, why, you know, Canadian hospitals have a much higher involuntary rate. That's a question that deserves some sort of further study. We have some ideas about that, but we don't have data that would really kind of answer that question clearly at this point. Go ahead. As I mentioned, this is just a snapshot that shows the majority of inpatient care is focusing on acute crisis. There's very little specific sort of treatment. There's some, but it's not in the hospital setting, it seems. This was just an exercise in having sites describe in their own words what their model of care is. And so we plugged all those kind of descriptions into a word cloud, and this is what we got. So again, it speaks to, I mean, obviously what you see is a very wide range of descriptions, but the things that really kind of characterize the models have to do with stabilization, crisis assessment, short-term, acute. Those are some of the words that really pop out. So really trying to sort of characterize it as a system that perhaps is more in response to more acute needs, as opposed to providing in the hospital setting anyway some of the longer-term treatment or intervention at a tertiary level. Go ahead, Lisa. Some of the indicators that we surveyed were around staffing. So we asked units to identify how many full-time equivalents they had across a range of professional groups. And so clearly, nursing plays a very big role in inpatient care, followed by child and youth counselors, which are called different things in different provinces, but those two professional groups are typically providing the direct care, frontline care on the units. Social work is very prominent, as is obviously psychiatry, but to a lesser degree. And then you see some of the other disciplines like psychology or teachers. Many units have teachers or other disciplines that provide care. But I think this really kind of captures as well the acute crisis nature, right, of what care looks like. We also, on the next slide, we looked at, so those numbers I just showed you just show you total FTEs across the country. This slide breaks it down into the average FTE per bed of these select professional groups. And again, so you see the predominance of nursing being the highest sort of allotment of full-time equivalents per inpatient psychiatry bed. Down to some very, very low numbers for other health professionals. Psychiatry is quite low. Psychology and OT are even lower. But it gives you a sense of, and then the range, right? There's quite a range. Some sites have none of those disciplines, and some of them have, quite a bit. But it just gives you a snapshot, sort of more equalizing the stats across beds. We asked people to provide data or estimates if they didn't have access to actual data on the reasons that children and youth were being admitted to their units. And so, first of all, the thing to point out is that only 16% of the units actually said they had actual data to report. So this is not an indicator, to our knowledge, that is being tracked in any consistent way across inpatient care, which is a concern. But the majority would say that suicide and self-harm, risk of that, is the main reason for admission, followed by harm to others, inability to function, and you'll notice these reasons are very much tied to involuntary admission criteria under the Mental Health Act. So reasons why kids would be admitted involuntarily. Less severe risks were noted in about half of the cases. And so really our inpatient care is geared towards, I think, sort of admitting children to keep them safe from themselves or to keep others safe. And again, we need to work on improving our access to real data on these indicators. But it seems that hospitalization is a response to community concerns around managing kids' safety. And just to sort of tie it back again to the fact that almost half of our admissions are involuntary, and that's much higher compared to other international rates. This slide just shows the distribution of admissions across gender and age. And so we see that for females, well, the first thing you'll notice is that females are much more likely to be admitted than males. We have many more teenage girls in inpatient care than we do teenage boys. And that the age distribution shifts as well. So for girls, 13 to 15 is sort of the more typical age, whereas for boys, we tend to see higher numbers of boys in the older adolescent age, which again is very similar to international patterns of admission data. Okay. this just shows the breakdown of diagnosis. And so these data do not include Ontario because that's not a question that we have included in our surveys, just because in our experience, the data that we get back is not always accessible to units. However, what you can see there is that just over half of the diagnoses would fall into the categories of depression, psychosis, an anxiety disorder, or PTSD. And so those are the primary things that we are seeing in inpatient care. But you can also see with the other categories some of the other things that are presenting on inpatient units across the country. Go ahead. And some other key indicators, but broken down by the type of unit. So it doesn't make sense to look at average length of stay and compare acute units with longer-term treatment units. So we've pulled those out just to get a sense of what those indicators look like. You can see definitely acute crisis units have much more volume and quite a range. You know, some units as high as over 500 discharges a year. The average length of stay is obviously shorter, an average of 10 days for acute units versus 43 days on average for planned treatment units. Length of stay ranges. It's interesting though, even on acute crisis units, you can get some pretty long lengths of stay. And we don't have data to explain, you know, who those kids are or why they're staying longer. We do know from some previous surveying that kids with a diagnosis of psychosis or with intellectual or developmental or eating disorders do tend to have longer lengths of stay, even in crisis care. But nonetheless, we do see that range. Readmission rates within a month are relatively low across. Much lower, obviously, in planned treatment units. And occupancy is about the same. And the rate of occupancy is interesting because there's international literature that would suggest that, you know, a good functioning crisis model unit would have an 80% occupancy because you always need to have the capacity to respond flexibly for crisis. And so to be at 100 or over 100% occupancy all the time, you're going to end up with, you know, blocks in the system. And I mean, you can see there by the range that some units are operating, you know, one as high as 123% occupancy. But we would really, you know, on average, we're sort of hitting that target. Okay, go ahead. One of the other indicators that we wanted to be tracking, which ties into some of the ideas around standards and quality care, is how units engage patients and their caregivers and the community. And so we asked them, you know, how often would you have, you know, engage patients and caregivers and community in the development of a care plan, in discharge planning? Do you provide a written discharge summary upon discharge? And so I think, you know, overall, units are reporting that they're doing pretty good at those activities and engaging patients and caregivers. What's missing here, of course, is the patient voice and the caregiver and community voice in terms of how much they feel they've been engaged. We don't have that data. But that would be an interesting thing to also, you know, think about surveying, getting their voice to get a sense of their experience of inpatient care. Go ahead, Lisa. And again, another important indicator had to do with use of restrictive interventions. And so, again, you see a lot of use of seclusion or quiet rooms. Over 85% of units report having a seclusion room. 82% report using chemical restraints to manage difficult situations. And then about 2/3 using a manual hands-on or some type of physical restraint. And then a smaller proportion of other kinds of restraints are reported. Pinel restraints or some other 4-point restraint, not as frequently used as the other interventions. Go ahead. And again, really concerning that the data that I just showed you, only 14% of sites were able to tap into actual data that is being tracked on use of restrictive interventions. Almost half are estimating. A third of units say they actually don't track that information, and some units just didn't respond to that question. And so some of the comments we got were, well, the hospital tracks that, but we can't extract that, right? Like it's within the medical record or it's somehow in an electronic record, and there's no way to easily access those data. So, you know, again, it's an area for improvement, I think, but as an important standard around, you know, safety on unit, safety for staff, safety for parents. This is an area that we feel, based on this survey data, that we could be doing a better job of paying attention to. And I think, Lisa, I think that's the last. Oh no, we got one more. Hit it again. We also were curious about whether units are tracking outcomes or using standardized assessments for treatment planning. And well, you can see it for yourself. We're about half and half. But just under half of the units say, yes, we're doing that. And of those units, you see the breakdown of the kinds of tools that are being used. Not a lot of consistency, and there were some regional patterns that came out as well. I believe it's the Alberta units, some and others in the Western provinces are using the HANOSCA, which is, for those who don't know, the Health of the Nation's outcome scale for children and adolescents, and that seemed to be consistently across provincial units. Whereas, you know, for the rest of the country, there's really no consistency at all. And others are using, you know, report using a variety of other measures. So it's really an area where we're not, you know, standardized at all. But what's concerning is that half the units aren't doing it at all. They report they are not using any kind of standardized tool for treatment planning or for outcomes tracking. So clearly there's a lot of work that we can do in this area as well. And over the years that we've surveyed, we really haven't seen a lot of movement on this bar. It seems to be something that units want to do, but don't have the capacity or resources to do in any systematic way, which makes benchmarking surveying very hard because people don't typically have access to data. And so that's been a challenge as well. And now I think we're done. So I'm happy to take any questions or clarification, and any of that.
All right, thanks so much, Stephanie. That was great. Does anybody have any questions or comments on what Stephanie's presented? Anything surprising?
It's Jana Davidson. As always, Stephanie, thank you for the great work that you're doing.
Thank you, Jana.
We're continuing to work on adapting the on-CAPE standards for the BC context, and have a good participation from our inpatient units provincially. So hopefully we'll complete that work this year. Yes,
well, we're looking forward to hearing how you're doing with that as well. I didn't speak a whole lot about the standards because I think Joe Percy spoke to your group a month or so ago, and I think he may have talked more about the standards that OnCapes has developed. Is that right, Lisa?
Yeah. Yes.
Okay. Yeah. Good. Yeah, well, and that's been the beauty of, I think, doing this work is furthering those connections and then working together, right, to kind of to spread that and to build on what's been done, not needing to replicate it, but building on it and adapting it for your local context. It's been one of the most gratifying things, I think, about this work for me.
This is Lisa. I just find it, I guess I shouldn't be shocked by it, but I'm always surprised a little bit when there is no data, like there's no easy way to get data on
Yeah.
on these big questions. And how, you know, if people are recognizing that there is a crisis, isn't that sort of the ministries? They all want data to support providing more services or changing the system or doing whatever it is they need to do. But then the system isn't set up to collect the data in the first place. So I find it mind-boggling. So I'm just expressing my confusion.
Yes. Yes, well, I mean, that's been our experience all along. Like I said, even when we started this whole thing, and the ministry didn't even have a clear list to share with us about where these units were. So, even at that level, it's shocking. I think more and more as hospitals go to electronic health records, certainly here at CHEO, we've over the last year we have switched to the Epic system. I know there are many different ones out there, and certainly we've been doing work to try to optimize our ability to pull data reports out of that, because there's a lot of data that's in there, and it's just about how to ask the right questions to get it out so that you can use it, right?
Yeah.
But when you still are doing paper charting, and there are still units that rely on manual documentation, then that's very hard to extract without significant investment in human resources. So hopefully that'll be a problem that becomes less and less of a problem moving forward.
But then and then we have that's the inpatient side of things, and then you have the community side where, so many of the services are provided, and how can we sort of relate those two different types of data, or how do you collect data in the community that is helpful, to the inpatient? Because all of these kids are, I think, no, I shouldn't say all these kids, but some of these kids are sort of going in and out, or if they have more attention in the community, they might end up in an inpatient or in a crisis situation. So it's just like, how does that,
right?
How do we make that information flow better?
Well, remember that picture I showed of the silos?
Yeah, yes.
Right? So I think we still have huge silos where you have hospital-based silo, you have community service silo, you have education silo, right? And the information isn't easily flowing because of lots of barriers there, whether it's, different ministries funding those different silos. There's no integrated record that follows kids from hospital to community care or from community to hospital care. And I don't know the state of it across the country, but I imagine it's very, similar in different places. Maybe some places have better flow, but it seems to me that that's a big barrier.
Well, it's interesting. Last week I came across, and I was like, how did I not know this? But I came across a report called Story of Transformation in Youth Mental Health in the Province of New Brunswick. And it's about how they've integrated their systems, a provincial integrated service delivery framework, where education, social services, and health are all actually working together for youth, for adolescent mental health. So I'll send out, if people aren't aware of it, I will send it out to everybody, because it's like,
that would be interesting to see. Yeah.
And again, why do we not know about this? So they've launched, they piloted it in some areas of the province, and then they rolled it out in January of this year, province-wide. So it's anyways.
Right, and I think there's some, in some areas, for example, where you have a very integrated local continuum of care. And so, certain hospital inpatient units are going to function differently because of the system around them, the context in which they're working and connected. And that can affect all of those indicators, lengths of stay. It can affect, your reasons for admission, your involuntary rates, readmission rates, versus, a unit or sort of collection of services that are not well integrated. And there's just a lack of systematization, right? There's just no organization to it. And it doesn't help that, our health services are funded provincially. So, you have different systems depending on the province you're in. So, I mean, that's encouraging to hear that New Brunswick has moved in that direction. I'm just curious from others who are on the call if any of these data are surprising or not surprising. I mean, I know not everybody is connected to inpatient mental health, but were there any things that jumped out at people?
Steph, it's Kyle here. Thanks for the presentation. I guess not many of the things have jumped out at me just because I've seen these stats in the past, but again, I always am surprised, like you were mentioning before, about the whole data piece, that some people don't track certain things like restraints and stuff. And I guess deep down inside, I think that, we do track it, or people must track it. It's just that finding it and getting it is kind of the challenging piece. And I know I initially ran into some difficulties here, thinking that it was going to be tough to pull it out, but then just asking around, eventually it kind of became easier, and I ended up being able to get the data. So,
well, that's good.
No surprises from me, but other than, I guess it always is surprising that we're not tracking this stuff in, 2018, right?
Right. Well, yeah, for sure. I think too, there's a different. I think these things get documented clinically in as they should, but it's then how do you? It's for the purpose of compiling it, right, or reporting it. That's difficult for people. Either they don't do it in that way, or it's captured in such a way that it's hard to extract. So you're right. Sometimes what we've done with the benchmarking surveys is often a provocative question to get people to think, oh, should I be tracking that? Is that an important indicator? And if I can't do it now, how can I start to ask, who do I ask? Where do I go within my agency, within my hospital, to get at that data? Recently, within the last year or two, our benchmarking survey has been now linked and integrated with our standards document. And so, again, the idea being that the indicators that we're asking people to look at are things that we feel are important because they're tied to a standard. Because it's tied to a quality indicator or quality care. And I think there has been some consciousness raising around some of these issues, which is, always a good thing.
Yep, and it's, like you mentioned, I don't know, we're getting a lot more information than we were several years ago, so I think the more information we have, the better it is.
That's great. Thanks so much, Stephanie. And
my pleasure.
Any other final questions or thoughts from anybody about what we've just heard?
For those of us who aren't able to join by computer, will we be getting the slides?
Yes, and it is recorded, so when you have an opportunity, you can actually go back and watch and listen to the presentation as well.
Great.
Great, thank you.
Great. Well, thanks for the opportunity, Lisa, to come and share what we're doing. And
sorry for the rocky
hear
start.
from others. Well, sorry, that's partly my fault too, but I'm glad we got it working.
Yeah.
Good.
All right.
Okay, well, I will sign off and have a good rest of your meeting, and thanks for everybody's participation.
Thanks very much.
Okay, bye now.
Bye. So there's not really much more on the agenda. I was just I can give a little bit of an update. We had I've spoken previously about um, working with health standards organizations. So we're in the midst of getting our working group going and connecting with their technical committee about sort of developing some standards that are complementary to their existing standards, but are more geared towards children and adolescents. So we might be coming back to this group with some questions about that, just to make sure that we're not biting off more than we can chew, and we're also not making it so high level as it's not worthwhile. So it's always that fine balance. So that's an update I can share. And I will share that report that I had mentioned about New Brunswick for people. Some of you may have read it, may have already be familiar with it, but I thought it would be an interesting read. And I don't know if anybody else around the table has anything interesting or exciting going on in their organizations that they wanted to share. I just got a message. Go ahead.
Hi, it's Jana Davidson. Sorry, I had to step away. We had a staff member caught in an elevator.
Oh dear.
Yeah, just in terms of updates, we're about to launch a BC version of the MCPAP program that was developed out of Massachusetts and Boston Children's Hospital, which is a provider support program that will be focused on child and youth mental health and substance use, and we'll be particularly focusing on our more rural, remote areas of the province. We're hoping to go live in September. So this is a little bit different than Project ECHO, which some of you may be familiar with, and is more of a generally available consultation service for navigation, indirect consultation, at times direct consultation, and continuing professional development that's multidisciplinary and available Monday to Friday, 8:30 to 4:30 kind of hours, or 8 to 5, we're not sure yet. And there'll always be somebody at the end of the phone for a provider to call. And so we're hoping it will be picked up by primary care providers, pediatricians, child and youth mental health teams, and others across the province in the rural, remote areas that we're targeting.
So that's, I'm sorry, you were going in and out a little bit. So that's to sort of build capacity of those and to help support the rural and remote areas in providing services?
Yes. So it's a provider support program.
Yeah.
So there'll be psychologists, addiction medicine specialists, psychiatrists, an intake kind of care navigator role, those that call in can be directed to any of the specialists. It's an interdisciplinary team, and they'll be involved in providing indirect consultation, direct consultation where it's required, and continuing professional development and resources.
Great. Very exciting. Is that, Lindsay, is that sort of similar, a little bit similar to what you're doing up there? To your program? Oh, maybe she's gone. I did have another comment from somebody in the chat box here. It says, it's clear from the statistics that there's an acute care focus with very little intervention or rehab. Is this the status quo, or is there an appetite to advocate for change? That's from Sandra. So does anybody have any?
It's Kyle here. Part of me wonders if more community-based or outpatient things were captured, if that would kind of pick up that end of it.
Yeah.
I think that in inpatient mental health, that such a large focus is essentially acute crisis stabilization, and then the more longer-term intervention in rehab happens as an outpatient.
Mm-hmm.
And part of me is, if in the on-campus standards, if that's what it's capturing, it's capturing the inpatient units. And
yeah,
I guess when somebody's acutely stabilized, yeah, the other stuff, the hard work, the long-term work happens on an outpatient basis, which isn't captured in that.
So that's an interesting road to go down too. So how do we? That information's got to be somewhere as well, but in so many different places and collected in so many different.
Well, to be honest, it might be even easier to grab, because in Ontario, at least within our site, the outpatient stuff's all controlled under the MCYS, Ministry of Child and Youth. The amount of metrics that they require is phenomenal. Like, it's actually, it's a lot. So it wouldn't surprise me if the information is accessible. You need to know who to ask, I guess. So,
I suppose, yeah.
But the majority of us are all Ministry of Health.
Yeah.
I know that for our program, half of my programs are Ministry of Health, and then another half are Ministry of Child and Youth Services. So it's a little bit different. I don't know if anybody else deals with that too. So.
And I imagine the other provinces are similar. Right. So thank you, everybody. We're at the top of the hour, and I will prepare a bit of a summary of our call. I will send the link to the presentation and also the slides out to everybody as well. And we'll talk again in July.
Great. Thanks. Bye.
Thank you.
Thanks.
Bye-bye.